Hello, and welcome to today's health webinar. This episode is brought to you by our friends at Philips. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Francesca Wutke.
Hello, everyone, and thank you for joining us today at Rethinking Telemetry from Overuse to Optimal Care. Telemetry, continuous remote monitoring of cardiac rhythm and sometimes specific oxygen, is a critical tool in modern hospitals. But when used without clear clinical justification, it can create more problems than it solves. Alarm fatigue, unnecessary testing, insufficient workflows, and buried insights are just a few of the unintended consequences facing frontline teams. Today, we're joined by two great thought leaders in the space, Dr. Jacob Turmel and Cindy Welsh. If I can ask you both to please introduce yourselves, we'll get right into it.
Sure, I'll start.
Cindy, go ahead.
Okay. Good afternoon. Thank you, everyone, for joining us and giving us the opportunity to have this discussion. I am Cindy Welsh, immediate past Vice President of Teleacute and Respiratory Care Services for Advocate Health, which is an integrated delivery network in the Midwest and Southeast regions of the United States.
Hi, everybody. I am Jacob Turmel. I'm the Chief Clinical Officer for Philips. I'm a nurse by background, been a nurse for about 26 years. I'm a nurse practitioner by training, worked cardiology my entire career. Been doing alarm management and CMU workflow since 2014, since the National Patient Safety Goal came out and the Joint Commission said, hey, we need to fix this problem. And here we are still today working on it. So excited for today's webinar. I think we have lots of opportunities to talk about some best practices and what we're seeing out there in the market. And Cindy, very excited to have this conversation with you. Cindy and I have worked together for many years, so very excited to engage in this conversation.
It might go all the way back to 2014 when the goal came out and we thought, oh, we'll put together a little task force and get this fixed. And here we are still today having the discussions, right?
Yeah, absolutely. It's not a one and done project. That's what you see when you're
all.
working on alarm management and teleuse.
Well, we're all really grateful to the two of you to have this great conversation. I'm Francesca Wutke. I'm the Head of Insights and Advisory at Health, and I'll be leading you through this discussion. It would be great if you guys can help us set the scene, understand, for those that aren't as familiar with telemetry, what that involves, what some of the problems with its overuse might be.
Cindy, do you want to start?
Sure. So telemetry in our health system, which I'm guessing is very similar to anybody else from a health system or hospital, is both a gift and a challenge at the same time, because I think, we certainly love the technology and what it can bring to help us manage our patients. And yet we know that people become very dependent on that as a way to help manage patients. And so we see a lot of overuse. So in our health system, we really, we took kind of a two-pronged approach to looking at this. One was, really, how do we create efficiencies in workflow so that we aren't having, nuisance alarms and alarm fatigue as a result of that, and making sure that our patients are correctly monitored and, not being misidentified because, of telebox issues and things like that. And then the other was, how do we relieve the burden on the bedside staff? Because as you know, if we can have these monitors in place, and if somebody isn't looking at what the waveforms are showing them and intervening appropriately, then you have patient safety events. So for us, the solution was to centralize that monitoring in a remote site and do, the interpretation and the notifications by that central team to all of our hospital sites, which, is great. It's been a wonderful, from a patient safety perspective, we've really managed to decrease our serious safety events and see what the cause of the serious safety events evolve over time. And, it's also a challenge because you have to keep people competent in, both at the bedside and in the central monitoring area.
Yeah, I agree with you, Cindy. CMUs have definitely been on the rise. I see it whenever I'm out working with hospitals each week. Customers come to us every week saying we want to build a CMU because we've had a safety event, or we want to avoid a safety event. So that CMU is really important. You know, Francesca, when I think back, whenever I used to work in a hospital, I'm going to date myself a little bit. This has been about 10 years ago. All of the literature was coming out around alarm management and around teleutilization. What we realized is that overusing tele was leading to more alarm fatigue. When we're not monitoring the right patients, we're getting alarms that don't matter, and the nurses become numb. They become kind of like the cry wolf syndrome, where they just don't even hear them anymore.
Mhm.
And where I used to work, the hospital I used to work at, we would monitor anybody. You came in with a broken finger, you were going on a heart monitor. And there was a perception from our physician colleagues that if I put the patient on the monitor, we're going to watch them closer. And in actuality, what we saw in practice is the nurses would say, oh, that patient's on the monitor. I can move on to my next patient now. So we weren't watching them closer. We were actually using this device to monitor them. The other thing that was really interesting that I noticed in some of the work I was doing is we were monitoring patients for the wrong reasons. We weren't looking at AHA ACC guidelines from 2017. And I think there was actually a revision in like 2007. We weren't looking at those guidelines to say, what are the reasons we should be monitoring? We should be monitoring for ST elevation, arrhythmias, and QTC prolongation. So if you look at the criteria, those are the three main criteria for monitoring in the guidelines. We were monitoring because we were concerned the patient may deteriorate. We were concerned the patient may show signs of sepsis. We were concerned about bleeding risk. Those are all late things that a cardiac, or those are all things that a cardiac monitor are going to pick up late. So we really weren't monitoring for the right reasons. And the nurses really start to devalue cardiac monitoring when we're monitoring on every patient. I use the ortho patient. So if there's any ortho nurses out there, I apologize. But we love to monitor ortho patients that come in for a hip surgery and they have a history of something. Doesn't necessarily need cardiac monitoring for this acute event that's unrelated to their cardiac history. So we definitely saw overuse. And a big part of that reason is because we've expanded the capacity to monitor patients anywhere in the hospital. It used to be that they were all in one cardiac unit, but what we found is we were moving these patients to a cardiac unit, but they had an oncology diagnosis. And so you were expecting these heart nurses to manage an oncology diagnosis. And so now, instead of moving the patient to the care, we're bringing the care to the patient, which means we're monitoring patients anywhere, which is great, but it also has led to overuse.
Yeah,
Jacob, I
Jacob,
find it so,
sorry,
please,
go ahead.
Cindy, go on.
I'm going to change
No.
the subject, so go ahead.
Okay. No, I was just saying, I find it so interesting that, nurses have one of the hardest jobs in the world to do. And putting patients on a monitor is a mechanism to unburden the nursing staff and make sure that the patients are really well looked after, which is obviously the goal of good patient care. But it almost seems like that surrogate, when not applied correctly, can do more harm than good. If you're overwhelming the system without a good alert protocol, to put it in one way, then it's very difficult to know how to tease out the truth from the noise. So it seems that first, triaging patients whether or not they should be monitored, and then second, having a reliable system of alerts really allows you to deliver patient care in a much more streamlined and patient-centric way.
Mhm.
Yeah, I think that ties nicely to what I was going to pick up on Jacob's statements about, you should be monitoring ST segment elevation. And for us in our system, when we first started our central tele, we thought, if it's something we can turn on and monitor, let's do it. So we, had gone from previously not having that turned on to thinking we were making our patients safer because we had this extra alarm. And while there is most definitely a time and place for that monitoring, and there's specific medications and arrhythmias that we would definitely want to be looking for that. A couple things we learned is, one, that's a trend. That's not a thing that in and of itself is going to tell you something is happening with the patient. It's really something you have to be paying attention to over time. And second, it led very, very quickly to alarm fatigue and missing other more important alarms because such a high volume of that. I think we actually collected for one 12-hour shift, there were over 5,000 alarms for ST segment elevation in one hospital. So, I mean, it's a very useful tool for a very specific patient population, but it can detract from those really important arrhythmias that you want to make sure you're getting intervention immediately for, that are life-threatening. So that was something we learned, unfortunately, because of a safety event, because we had a patient who, had a more important thing happening, and it was overridden by the volume of that ST segment elevation. So we have since, used that as a lesson learned and turned that alarm off unless it's for that specific patient population that needs it. And it has really helped with the credibility of the techs calling the bedside, because now they know it's not just, hey, can you go look or something like that. But I think, developing workflows that really enhance communication between the bedside and the tech wherever they're located, whether it's, locally in the hospital, it's probably not sitting on the nursing unit. It's probably, even if it's centralized in the hospital, probably in a separate area, or remotely like we are, completely offsite, but really putting those workflows in place for notifications and things like that help with that alarm fatigue and communication burnout.
Yeah. And Cindy, you're very right. ST alarms are one of the biggest nuisance alarms that are out there. So how do we balance the fact that we should be monitoring for STs, but we know that it's a big nuisance alarms? And I'll talk about Philips system. In the Philips system, when you turn on ST alarms and ST monitoring, it's looking at individual ST segments. It's not looking at consecutive heart leads or congruent heart leads like 2-3 AVF or inferior leads. It's looking at individual ones. Well, individual STs don't matter. It really matters if they're in those lead patterns. So we have what we call our ST map within Philips, where we get that visual that does exactly what you're talking about, Cindy. It gives us that trend over time to say, is this patient's STs elevating in those lead patterns that matter? Because that's what's relevant. And again, it's not for every patient. Guidelines tell us we should be monitoring post-cath, rule out MI, those types of patients that are at risk for occlusion or ischemia for ST elevation. But it's not for everyone. And it's certainly not for, the hip patient that came in that has a history of something.
Right. Yeah. And we actually found the maps to be very helpful. I think the challenge is when you take your eyes off of your 48 patients to look at that one patient's map, when it's
Yeah.
not a patient that, needs to have that, when it is that ortho patient, it's probably not helpful, but it is absolutely a beneficial tool for the right patient.
Yeah, absolutely.
And in the field, how do you see clinical leaders reassessing some of the telemetry practices, to drive that best care and to make sure that they're avoiding things like alarm fatigue?
Yeah, and I'll take this one, Cindy. So what we see is that when the work really came out around teleutilization, there were two ways to really focus on it from a workflow perspective. First was with the order. So do I time out an order and say my order expires at 48 hours, and then the nurse is responsible for getting an order to renew it if the physician thinks that that's relevant? The problem that we run into with that is that order expires and the nurse doesn't always notice that it expired. So now we're monitoring a patient without an order. Or the order expires, it pings the primary physician who may or may not even know the patient, and they're just clicking saying, yeah. I just need to get past that pop-up so I can do the orders I'm intending to put in. So not a lot of thought often goes into the order. I am more of a fan of looking at it on the back end. Let's get the patient on the monitor. That's fine, but let's monitor them for 48 hours. And then if they're arrhythmia free and don't meet other criteria, then that's really the time to say, let's get them off the monitor. So being a little bit more retroactive and or a little bit more reactive in that way seems to work better for organizations that I see. And some organizations do both. They have the orders that expire. They still are identifying them at 48 hours. And I think that's really helpful too. But putting those workflows into place that's really the trend that I'm seeing right now in the field.
I think Jacob did a site visit to our site because you're describing exactly the challenges we have been
I did.
experienced. Yeah, you have been there. I was teasing though. It's like you're reading our book, right? What we have done is we're one of the both. We have the 24, 48, 72-hour criteria. You know, theoretically, the only time a patient should be on continuous monitoring for their hospital stay is when they're in the ICU. A couple challenges you run into with that is the first time a nurse has the guts to discontinue the telemetry because the patient no longer meets the AHA criteria that we've defined in the EMR and discontinues the telemetry. And the physician feels like it shouldn't have been, but patient met the criteria to discontinue it, and they challenge the nurse will never do it again. So, you know, when you want to put a nurse-driven protocol, which can be very successful, we've had sites, specific units at sites, I'll say at least, that have been very successful at doing that. Generally, it requires a leader who's very consistently applying the criteria and who has a champion in the form of a cardiologist that will back them up when the physician challenges them. So that has been one of the ways we've seen that work successfully. I think the other challenge we have is in the EMR, depending on which one you're using, and the one we use, the order expires, but it still continues to run. There's not a good way to discontinue it, so to speak. It's also a challenge we have of, when a patient transfers from the ICU to the floor, to make sure that that order gets rewritten so that it doesn't become continuous telemetry. So I think that it's something clinicians are very aware of and trying to work closely with their partners, whether in IT or, in the monitoring arena, to correct so that we can make better use of telemetry for patients who need it. And we are not constantly buying more tele boxes because we need more patients on tele, because we've got those ortho and, other patients that don't particularly need it being monitored.
And Cindy, you bring up a very good point around the nurse-driven protocol. I do see organizations moving to that, where their practice guidelines within the state allow for it, and where their organizations allow for it, where it says, if my patient's met criteria at 48 hours and they've been arrhythmia free and their vital signs are stable and we check the list, then the nurse has the authority to automatically remove telemetry. What we found at our organization, I was working on a nurse-driven protocol where I used to work, was really trying to get the buy-in from the hospitalists. That was a key piece that we discovered. We really needed to get the hospitalists to own it. And then we also needed an EP doctor to really be that champion, much to what you were saying. No one is going to challenge an EP doctor when it comes to arrhythmias. They're going to say, that's not important. And everybody's going to be like, we agree, because the EP doctor has said it. So we were really trying to do that nurse-driven protocol and getting all the buy-in and support for that. But it really has made a huge difference in places that have been able to successfully implement a nurse-driven protocol.
So it seems like a combination of evidence-based guidelines, best practice, some automation within the back office itself, as well as integration with EMR, and then integration, with whatever systems are in place to order this care for patients. But it seems incredibly complex, and that there are a kind of number of steps that the nursing team still has to look after, and both in initiating, continuing monitoring, and then in terminating the telemetry.
Yeah, I think one more thing I'd like to add, if I can, is one of the things, I hope that the work is continuing. I'm not there to be partnering with the leader there, but one of the things we had been discussing as we were talking about this challenge of, getting telemetry discontinued before the patient's being wheeled out of the hospital to go home, is some things we had already done is the techs on the central monitoring unit already are monitoring. We created a telemetry list of patients so that we could see if a patient has discharge orders or if the telemetry order is expired. We can actually talk to the nurses at the bedside and let them know. And then that helps them. That again is just one more reminder to them to, review that medical record and see if they meet the criteria for discontinuation. But one of the other things we thought might be worth piloting is having the arrhythmia nurses that we're fortunate to have in the central monitoring area be the ones that apply the protocol. So instead of asking every, 800 nurses in a hospital to understand this, arrhythmias and criteria and all of that well enough to feel confident in discontinuing it, maybe we centralize that to a smaller group of people who have that expertise, have been doing this for years and years, and maybe create that credibility with the physicians that might challenge the decision, again, with probably the backup of a champion where needed. But that was one thing where we thought, sometimes you just get that when you have that inner rater reliability, because you decrease the number of people, when it's everybody's job, it's nobody's job. Let's make it one specific job. And maybe that would be a way to address those challenges.
Yeah, absolutely. So I think it's a mix of balancing the use of technology, with also some of the clinical necessity and the bandwidth of the teams. I think your point is really well taken. When it's everyone's job, it's no one's job, and I think that's when things start really falling through the cracks. As hospitals are deciding on their protocols, whether they're nurse driven, whether they're at the nursing station, remote, or really even off site, what are some of the decision points that hospitals go through to decide what's best, what's the best approach for their center or their system?
Yeah, I think the first thing is trying to distill down the guidelines. So that's the 2017 guidelines that are out there. If you've ever taken a look at it, it's a 40-page document. It is not the easiest thing to take and put into practice. And I think that's where a lot of organizations have really struggled, is how do I take these guidelines and put them into practice? So really leaning on organizations that have put practice guidelines into place and saying what is really out there is really helpful. Instead of trying to recreate the wheel, find out what other organizations are doing around criteria for appropriate use and how they've been able to implement it into an order set or into looking at them at 48 hours. The other thing that I think is really important is really developing your process around identifying those patients who at 48 or 72 hours have been arrhythmia free. Right now, that's a manual process. I will say at Philips, we have a tool that can help with that to identify those patients at 48 hours who have been arrhythmia free. So we can arm the nurse with the information they need when they go and have that conversation with the doctor. I can say, my patient Jacob has been arrhythmia free for 48 hours. It doesn't sound like they meet criteria anymore for cardiology. Vital signs are stable, or for monitoring, vital signs are stable, whatever it might be. And then that arms the nurse to have that conversation. And I think it's a change in culture too for nurses and doctors. We can't underestimate the amount of change in culture that it takes to implement new workflows like this, because nurses also feel that patients are better cared for if they're on telemetry. And nurses are really reluctant to give that up sometimes. So we have to let nurses understand and help them to understand that just like I'm trying to get rid of IV lines and oxygen and, Foley drains or Foley catheters and drains as my patient is progressing, telemetry is one more piece of equipment that I should be getting rid of as my patient is progressing and I'm working on getting them ready for discharge. So it's a change in culture that I think really has to come in. More than implementing a new workflow, it's really that change in culture I think that's most important.
So it's implementing the technology, changing the workflow, and then changing the mindset of the folks that are looking after the patient. So it's
Absolutely. Yeah,
quite
absolutely.
a process.
Yeah, I think that a couple of things I would add to that. I agree completely with Jacob. Don't try to reinvent the wheel. There are plenty of people out there that are doing this, that almost anyone you would call that's doing this is going to be more than happy to share their lessons learned with you. And so, do that, take it to heart and apply the things that other people have tried that didn't work. But also keep in mind that, Jacob so eloquently said it's a culture change, and every site has its own culture. So you have to really make sure that you're taking, whatever you can gather from other people that, have provided you information, but applying it, to your own culture. I think some of the other things people look at as they think about whether do we centralize or decentralize? There can be an argument made for monitoring patients either way. Some people feel like if I keep my patients, I'm only responsible for the 24 patients on my unit and it's done at the central station, that's the best way to do it. And I can tell you, when we centralized our telemetry offsite, we had 2 hospitals that were decentralized, and the rest, the other 6 were centralized within the hospital offsite. And it was the easiest to change the culture of the sites that had been decentralized, because they had no expectations about what central telemetry was. They just knew that they no longer had that responsibility and that we needed to make our workflows work and communication be successful. And I think, just to talk practically about why you would potentially centralize remotely is, look at what's the environment of almost any central tele area in a hospital. It's probably in a very small room with no windows, because there's such a premium for real estate in a hospital setting that sometimes it just makes sense to, besides the economies of scale you can get because they're small departments, they have small staffs, you have one call in, now you're pulling a nurse off the floor to be a tech because they can't, get anybody else to come in. So when you centralize it offsite for multiple hospitals, it allows you to have a bigger staff that gives you more resources. And it's also the downside is you're offsite, so you don't have more resources. You're dependent on what you have available. So that's like a whole another discussion. But from a clinical perspective, it's certainly the culture change.
Yeah, I think you bring up a good point, Cindy, too, around centralizing your CMUs. And I think when you look at centralizing your CMUs, and I know that's not the purpose of today's talk, but there's impacts for teleuse when you look at decentralized versus centralized. That centralized allows you to standardize. That's one of the best things. You mentioned it, economies of scale. I now can standardize and scale my workflow. So I know every monitor tech is looking for these patients that could potentially come off of the monitor because I've set that up as my standard workflow. I've set up as a standard workflow, the monitor tech is going to contact the nurse or the physician and say, hey, this patient's tele may need to be discontinued because they've met criteria, or however that might happen. But you set up those standard workflows and you can scale that across your organization. When you have CMUs that are in isolated pockets, it's not as easy to standardize and scale. So I think that's a big advantage of a CMU in this type of environment when you're looking at reducing the amount of tele. The other thing is, reducing the amount of tele is not about freeing up new telemetry boxes and having the monitor tech. So I'm only watching 20 patients now instead of the 40 I was watching. It's really about throughput. How do we get those patients out of the emergency department and into a monitored bed? I worked with a hospital in Tennessee that they're holding 40 to 60 telemetry patients every day in their emergency department waiting on cardiac monitor beds. So if we can free up that tele box and that bed so that that next patient can arrive, we've improved throughput. We got those patients out of the ED, got them into an inpatient bed where they can receive the care they need. That's why teleutilization to me is so important. I used to think it was all about cost reduction and we're avoiding all this unnecessary stuff, which is great, but it really is about that impact to throughput too.
So you guys have both touched on different models of workflows that may or may not work depending on what environment they're in. Can you share some more examples of some workflows that were redesigned and how they were redesigned to better surface some meaningful telemetry insights?
Yeah, I can talk, give an example. We have an algorithm in our CMU that allows us to respond to different types of alarms, lethal arrhythmias, blue alarms, yellow alarms, red, yellow, and blue alarms, we call them. So we developed this based on the AHA guidelines and, in conjunction with our EP physicians and cardiologists to make sure that, the interventions we prescribed were appropriate. And part of that built in our central teletext being able to call rapid response teams and code blues if necessary. And I think that in and of itself is a huge step, because that means that, people are putting trust in the monitor techs to recognize that something is happening. And rather than waste time by trying to call the bedside to say, hey, I think something's happening, can you go check? Then you're wasting precious minutes that we could be getting a team there to intervene. And so I think the, workflow first started out that we would just call the code. If it looked like it was, a lethal arrhythmia, it was a lethal arrhythmia, and we called it. And so you can imagine what would happen pretty quickly. The clinicians that were being pulled away from the bedside to respond to the code were not happy that the patient was sitting up eating lunch, and that's why they looked like they were in VFib. So we, pretty quickly learned that we needed to modify that algorithm. So, and we had data. I mean, we collected a lot. We're a very data-driven organization, so we're constantly looking at our data to help drive our, decision-making and changes to these algorithms. And so we now have put in place when it's questionable, and there are ways you can use the Philips monitoring system to determine whether something is questionable. You get multiple lead looks and things like that. We do have that one phone call to the nurse to say, hey, I'm not sure about this patient. Can you go in and look? And so that made a significant difference in how we deployed our precious resources at the bedside to intervene for patients. And yet we've seen much more appropriate intervention in terms of patients when we do deploy remotely, from the remote site to the bedside, more appropriate use of those teams, Code Blue and Rapid Response, so that more patients are getting the appropriate intervention and, potentially being transferred to the ICU because it was something that needed. So that was, it sounds pretty simple, but it took us a long time to really develop that and refine that workflow with our data to make those changes that have, in the long term, really changed what we see serious safety events occurring for.
Yeah, I think that was a great example, Cindy, of you guys looking at your data and looking at your workflows to say what makes sense, because what we're doing doesn't make sense. So let's pivot and do something that will. The other workflow that I was thinking of, Francesca, as you asked the question, is really around the algorithm to discontinue the monitor. So a lot of organizations have created algorithms to say if X, Y, and Z criteria are met, then the patient's eligible for discharge. And it's typically length of time on tele. So 48 hours is what I see as the typical time marker for when a patient could come off. And then are they arrhythmia free? So I've identified Jacob is available to come off the tele. I now have to go back, do research through all of his alarms to see, did he have any meaningful alarms that we need to be aware of? And then we have to make sure the patient's stable. And from a clinical perspective, it makes sense for them to come off the monitor. So we created these algorithms, which are great in theory. But when I think about nursing workload and nursing competency, I don't know that this algorithm lines up to that as much as we would want. It added more work to the nurses, which is why we haven't really seen it take off as a workflow that has become standard, because there's a lot of digging that has to happen to get this information. The other thing is, much to what Cindy was saying earlier, if we don't have seasoned nurses that are ready to have those conversations, the first time one of our novice nurses gets told no, or gets told, why did you do that? Then they're not going to do it again, and your whole process is broken. So from a nursing satisfaction standpoint, I think it was good in theory, but I think we need to give them tools to help them take away the manual part of that process and get those key stakeholders on board, so that when the nurses do say, I think Jacob is ready to come off the tele, then the physician can say yes or no, but here's why. Here's my rationale. Let's leave them on. I think that's a key piece. That communication is a key piece of that.
So interesting. You mentioned two things that I wanted to drill down on. The first is, the nurses having the ability to change the algorithm. Cindy, you mentioned, to bring in more practical care versus just, what the alarms are telling us. So how do the nursing teams work together, with Philips in this case, to recreate those algorithms? And you also mentioned staff satisfaction. I think that's a huge component of this. How are these modified systems and modified algorithms really impacting the staff satisfaction and how able they are to do their jobs well.
Mhm. Yeah, I can start. So I think when we look at the algorithms and the first part of your question there, what really comes to mind is the amount of work that takes to do these different algorithms. So how do we lessen that work with technology? How do we have AI maybe that identifies these patients for us? Whatever it might be, we got to lessen that burden on the nursing staff. Nurses are stretched already. So we know we can't rely on the nurses to always do the work that we want them to do if it's not direct care. And then from a satisfaction part, I think about the nurses with overuse of tele. We think patients are safer. We think that they're being monitored closer. And so changing that mindset really is important. But we want to decrease the burden on the nursing staff. So any new workflow we put in place has to align with the workflow the nurses are already doing so that we can decrease that workload on them so that we're not adding additional work to them. Right now, nurses are stretched too thin for that.
Yeah, I agree, Jacob. I think a lot of what you said is very similar to what I would say. I think a couple things I'd add is one, I think it's really important as you're developing these algorithms that you are using the technology as a tool to help support the algorithm and that you're not creating an algorithm around the technology, which is very easy to get sucked into doing just because, um, it has a certain function. And so it's easy to say, how do we make something work around that function? And I think, Philips has been great partners with us in terms of helping to define how that technology can support the workflow and really looking at how they can, refine the functionality that the systems have. So I think that's one thing. The other thing we learned is don't have a knee-jerk reaction to changing your algorithm because of one event, because you
Mhm.
can get in the you know, circle of just constantly, and no one can keep up with it, and nobody knows what are we supposed to do now? What changed last week? I don't remember. So we really put, unless it's a life-threatening or life-changing change for the algorithm, we really evaluate that as a corporate committee every 6 months, and if nothing needs to be changed, we don't change it, because remember, every
Mhm.
time you make that change, again, that change management requires that somehow that gets communicated to thousands of, key stakeholders that need to know that has happened. So I think that being very deliberate in your evaluation of the algorithm and when and how you change it. And I think to Jacob's point about satisfaction, you've got to be able to answer the what's in it for me when you're making these changes or implementing these new workflows, because I have to understand why you're asking me to do something that I feel is adding more work to me, which maybe in the long run won't, but at least right now it feels like it. So help me understand how this, new technology or this new workflow is going to make my life easier, even if there is a learning curve, and then maybe I'll be more willing to adopt it.
Yeah.
Yeah.
Cindy, you are spot on with that. So one of the things I'm a huge advocate for is whenever we're doing any type of change management around alarms, is telling our stories. We've got to tell our
Mhm.
stories. We've got to tell our safety events because nurses think that doesn't happen here. That won't
Right.
happen to my unit. That won't happen to me. I'm a better nurse than that. So telling those stories so that they say that could happen to me, that has happened here, that happened on a unit just like mine, helps to give them that what's in it for me to make it
Mhm.
more realistic. We have to tell the stories. And I actually started all of my alarm management education and teleutilization education with a patient safety story. And I got approval from our risk managers and our quality people to tell the stories because I felt like it was so important that the nurses hear those stories. Um, and then Francesca, you asked about how can we continue? I think you had asked like, how do we partner with Philips? How do we partner to really make changes to those algorithms? And at Philips, we have clinical people that are responsible for just that. We work with executives like Cindy, like her teams on a daily basis to really come in and do that consultative approach to say, here's what we see for best practices. You're wanting to do it this way, but have you thought about maybe doing it this way instead? So we come in and we consult around those best practices. We also use data to help with consulting thing too. We are able to pull data and say, we're seeing that you're using this much telemetry or whatever it might look like, but really using data help drive those changes, I think is really important.
And you brought up something that I think is really important. It's not tech first, it's patient first, and patients are at the core. And so leveraging technology to improve patient care, we want our nurses to be able to do more with less and to improve the care that they're delivering and that the patients are receiving. But I think that's a maybe a key friction point where nurses may feel that putting more patients on for longer is resulting in best care, but it may or may not be. So, those are certainly changes in mindset. But it's also, Jacob, I really love that approach of storytelling. It's helping them understand this is meant as a tool to help you. Ultimately, you're making the decisions, but the better adapted the tool is for what you need to be doing, the better able you are to leverage the outputs there. So I thought that was a really interesting point, that that the keeping patient-centered care as the priority when applying technology, I think is so key. Jacob, you mentioned something, and of course we would be absolutely remiss in not mentioning AI in any webinar in this day and age. But how do you think AI or other kinds of predictive analytics can help refine telemetry monitoring both now and then in the future? What do you, if you're future gazing, what would you hope to see?
Yeah, I have a lot of thoughts on this. So we're asked about AI on a daily basis. What is Philips working on when it comes to AI? And while I can't go into specifics around what we're working on, I can tell you about a world in which we imagine certain possibilities. So imagine a world in which the monitor tech is no longer sitting there doing all of those caliper measurements, but just like on an EKG, the caliper measurements auto-populate to the wave strip, and the monitor tech just clicks and agrees. And those tick marks stay on the actual wave strip so that I, as the nurse, know what monitor or what segments that monitor tech actually measured, so I can validate and say, yes, I agree. Imagine a world in which a nurse or a monitor tech is not having to dig through 200 patients, whatever it might be, to figure out which ones have been on the monitor for 48 hours and have been arrhythmia free. What would it look like if AI does that for us automatically? So I think there's a lot of opportunities for AI within the tele space. The other thing is, instead of the monitor tech making their own interpretation, what would it look like if we overlay that strip with a computer generated interpretation that the monitor tech agrees with? So not to take away that skill set from the monitor tech or the nurse, but really augmenting the decisions they're making. One of the things that I've learned about AI, and this was really important for me because I didn't quite understand this at first, but AI is not meant to replace complex decision making. It is meant to assist in complex decision making. So if we had a computer generated interpretation on that rhythm strip, that monitor tech could say, yeah, that's exactly what I was thinking. Or maybe they think, I didn't think that exactly, but yep, that makes sense. So that's where I see monitoring going in the future, is more computer generated analysis of that rhythm strip, both from a measurement perspective as well as an interpretation perspective. More AI around identifying these patients for early discharge from monitoring system. I think those are going to be the big changes that we see with AI.
I think from a clinical perspective, I'd like to imagine that AI is actually trending data on these patients in the background and able to bring forth that this patient has had ST segment elevation in 3 leads for the last 30 minutes. Maybe now you better look at it.
Yeah.
Or some of the lethal arrhythmias that, or predictive modeling, like before we get to the VFib, how about the changes that are so subtle over time that unless I'm sitting there staring at that patient's rhythm strip, I'm not going to necessarily pick up on it, or I know that patient very well because I've been watching them for the last 3 days. These very subtle changes in heart rate and, the measurements that AI is helping me make and things like that. So I'm guessing that's probably a little farther down the road, but that's certainly something I would like to see more predictive modeling, which helps us, identify earlier some of these changes and prevent, um, the significant events that end up putting the patient in the ICU.
Yeah, Cindy, I think you're spot on, and I'm glad you brought that up. One of the things that we're really looking at is predicting AFib on patients. So both in an inpatient setting and an outpatient setting, how do we predict AFib? So hopefully we can intervene before a patient goes into AFib and we reduce their stroke risk by early identification. So we're partnering with vendors that are doing that today. So on an EKG, I don't know how they do it, but they can look at an EKG and determine if a patient's at risk for going into AFib. They're also looking at algorithms to predict if a patient's at risk for heart failure, all based on the EKG. So that predictive analysis is happening today, and I think that's going to explode in the future. So Cindy, you're spot on with that predictive analysis.
Have it by next week?
I don't know about next week, Cindy, but very soon I think we'll see it.
Great.
And what do you think it would look like, an ideal telemetry system would look like 5 to 10 years from now? If you can devise what would be the best case scenario.
Yeah, for me, it would be a wearable, so I don't have these clunky boxes that keep getting lost in the linen. It's just a patch that I put on the patient and they're able to be monitored to the same level of precision that we have now or better. That'd be my, and ideally some of this predictive modeling is incorporated 5 to 10 years from now so that we do have, we're using our text to really help interpret something versus, trying to watch 48 patients with such level of detail that, they can't take their eyes off of the rhythm strip to look at something that may help them predict yet, currently. That's where I'd like to
Yeah.
see.
I think Cindy is spot on with wearables. As we talk to customers and we say, what do you want in the next 5 years? That's what we hear is a wearable. And this wearable would do 1 to 2 waves of ECG. It would be able to monitor blood pressure, temperature, SpO2, position. It collects respirations. It collects all of our vital signs as well as our 1 to 2 waves of ECG. And then we're able to do that predictive analysis on that. And it's monitoring things that matter. So if I'm looking for sepsis screening, I'm going to get my heart rate. I'm going to get my other parameters that matter for sepsis, where my waveform is not going to tell me that. So I think that's a really key piece that we will see in the future. I think we will see it very soon. Companies are already working on these wearables. So I think we'll see that pretty soon, a wearable that will replace telemetry. We may still have a telemetry for maybe a little bit higher acuity, and maybe this wearable is for a lower acuity patient. So the right patient population is something that we'll have to think about, and then all the workflows associated with that. But I definitely think we'll see this wearable very soon. The other thing I think that we will see is more of the predictive analysis, like Cindy was saying. I definitely think that we will see a lot more of that coming to light. Like I said, we're partnering with companies right now. Anyamana in Boston is one that we're partnering with. They're doing this predictive analysis already for heart failure. We can be able to look at an EKG and say this patient's at risk for going into heart failure. Just from the EKG, I think we will see more of that. I do think that we'll start to see better clinical communication around alerts going out to nurses, and it will be more smart, or it'll be smarter, excuse me. It'll be smarter in how we're sending alerts out to nurses so that alerting, we're already seeing mobility as a key piece to cardiac monitoring. Nurses are not sitting at a nurse's station anymore. To use a phrase of one of my coworkers, nurses are natively mobile. They are moving. So we need to give them tools in the palm of their hand. So I think we'll see an explosion of mobility workflows as well, so that nurses are not having to go back to a central station to do their workflows. They can do that all from their phone.
And wouldn't it be amazing if a patient came into hospital, with some kind of a wearable, and then immediately the healthcare teams could just tap into the data there and keep an eye on them while they're around.
Yeah, absolutely.
So we would love to hear from our audience. Just as I'm looking now, we have over 100 participants. So if anyone would like to ask questions of our thought leaders, Jacob and Cindy, please feel free to ask them in the Q&A. In thinking about how we evolve these systems that are, so integrated and embedded into the hospital systems, and with the pace of change that AI is allowing us, how do we stay on top, and how do we make sure that the innovation is iterative, but is also fitting within the framework of current guidelines and the hospital procurement gauntlets, which we all know are notoriously long and very hard to navigate.
Yeah, so a couple of thoughts on that. I think first, partnering with your vendors is really important. Your vendors are going to stay on top of what technology is new, whatever is latest and greatest. So your vendor partnership is really important. Cindy mentioned this before, and I love that Cindy mentioned Philips as a partner, because your vendors, that relationship is no longer transactional. We're not just coming in to sell you a product. We're coming in to help you change your workflows. And that takes partnership, that takes change management, that takes leadership accountability, all of those great things to change workflow. We come in from a consultative perspective to help you do that. So really partnering with your vendors, I think, is really important. The other thing that I think, if you're looking at how you can really do this well, is asking around, seeing who's already done it and learning from them. You said we have 100 participants on here. How great would it be if there was 100 participants that created a forum to talk about teleutilization and share best practices? So is there space to do that? Can we do that? At Philips, we've recognized CMU as a new big initiative that a lot of organizations are undertaking. So we've actually pulled together a CMU summit that we've hosted twice now, where thought leaders can come together and share their ideas around best practices from a CMU perspective. But it also is looking at alarm management and teleutilization, because those are vital components of a CMU. And we have an advisory board that Cindy is part of that guides us to tell us what workflows should we be focusing on, what are the latest trends in the healthcare setting that we need to be aware of as a vendor partner. So really looking at forums for customers to join in like that, to learn from each other what best practices are out there. We can do some of those dot connections, but really having those resources to reach out to, I think, is really important.
Yeah, I agree. And I think to, piggyback on or jump on Jacob's terminology of natively mobile, I think that, one of the things that's so important going forward is that our technology integrates with whatever, with the EMR, with each other, with, whatever. I think that, when you go down to an ED right now and you see telemedicine, you see 6 or 8 carts sitting there, for one for each vendor. So I think, going forward, we want to make sure that these tools are all working in a way that decreases the burden of work and knowledge that the nurses have to be able to utilize that technology. So having, my rhythm strip and, some predictive things and all of that on my little, mobile device, so that I can be looking, in this patient's room, but know what's going on in my patient's room down the hall, is going to be really important.
Mm-hmm.
And Jacob and Cindy, just in the last few minutes, we have a great question from one of our participants, and they ask, how useful is data obtained from consumer wearables, for example, an Apple Watch, in the clinical setting?
Yeah, I heard something the other day, and I'm probably going to not say this correctly, but I'll do my best, that your Apple Watch performs more EKGs than you get in a hospital. So we know there's valuable information in those wearables. We are really looking at, from a Philips perspective, how we can be more open sourced to start pulling in some of that wearable data. I don't know that we'll have this tomorrow, but we are looking at how do we use that data in a very informed way, in a very thoughtful way, because patients do come in. They're all wearing their blood glucose monitors. They're all wearing their watches. So we are looking at how we can pull that data in to help with the algorithms that we have in our monitor system. But I do think that that's important for us to look at. Consumers trust their Apple Watches. They trust their blood glucose monitors. They trust whatever things are going to be coming out in the future for wearables. So we are looking at Philips and how we can be more open source for those devices.
Yeah, I have to agree. I think, I'm a big fan of trends. And so when you come in with your Apple Watch or your glucose monitor and I can look back for a month versus what's happening right now as you're sitting in front of me, that's got to be useful information. I think, exactly like Jacob's saying, is the challenge is it's data overload, right? I mean, there's
Mhm.
hundreds of thousands of pieces of data. So how do we get the ones that are really pertinent to whatever the episode is right now in the acute care setting that really helps drive that, care plan?
And one last one in the last minute we have, technology used to be the biggest challenge in monitoring, and it no longer is. We can build virtually anything. Can you, either of you or both of you, comment on some of the investment in infrastructure, payment or reimbursement strategies that stand in the way of real adoption of all of these practices?
And I think we can say thank you, COVID. That's maybe one of the only things we can say thank you for in terms of reimbursement coming a little farther ahead. But I think we're still a long way off to it being, remote care being perceived as equivalent to face to face. So reimbursement is still really variable, particularly by state, I believe. And I think it's still in its infancy.
Yeah, and it's interesting when we think about reimbursement. Cindy, I don't know what y'all did at your hospital, but we didn't charge for telemetry. It was included in our bed
Charge.
cost.
Yeah.
You did charge?
No, saying room
Y'all
charge. It's
didn't.
part of the room
Room-
charge. Yeah.
Yeah, it was embedded in our room charge. So
Yeah.
you just got that as part of the overall package for the room charge. Some places do charge for specifically for telemetry, which is fine too. It just depends on how your organization is set up and really what your state allows for and what you're going to get reimbursed for. So those changes to reimbursement really from where I used to work would not have impacted us from a tele perspective.
Mm.
I have worked with some organizations, and Cindy, I don't know if y'all were looking at doing this or not, but the organizations were looking at outsourcing telemetry. So they may be monitoring Advocate, but maybe they decide they're going to monitor a hospital down the road that's not part of Advocate, and they charge that hospital for those
Yeah.
services. I don't know if y'all were looking at anything like that as part of
Yeah,
your monitor room.
we absolutely did it in our tele-ICU. We certainly are open to that in the central telemetry area. I think part of our challenge there was really getting our staff mature enough to be able to take that on for an outside customer. So I think
Yeah.
it's down the road for sure, something that's a goal, but we
Yeah.
had not done it yet.
Well,
But
I
that
wanted to
tends to be
thank
a subscription model, though, when you do that, when you do
Yeah.
outreach,
Yeah.
as opposed to reimbursement by CMS.
Mhm.
Well, we're at the top of the hour now, so I wanted to thank Jacob and Cindy for their great insights. I know I learned a ton during this webinar, and thank you to Philips, our sponsor. And thanks for joining us.
Thank you to Philips and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Las Vegas, October 19th to 22nd for Health USA,